I'll start with the first talk, and that will be on the femtolaser assisted cataract surgery in complex cases. Hi, Gaurav. Morning. Come. Well, can I have my slides? Yeah. Okay, so I'll be talking about femtolaser assisted cataract surgery for complex cases. So as you all know that femtolaser cataract surgery is the new kid on the block for more than a decade now. And in my personal practice, I'll be doing about 80% of my cases through the femtolaser assisted cataract surgery. Now, in routine cases, femtolaser cataract surgery obviously has a role, but the role gets exemplified or magnified, as one would wish to say, when you are working in challenging situations. So let's come to the first challenging situation, and that is the posterior polar cataract. Now let me just tell you that in posterior polar cataract, ever since we switched over to the femtolaser assisted cataract surgery, we have not had any nucleus drop, and I'll tell you why. This is the paper that we published in the Journal of Cataract and Refractive Surgery, wherein we have said that the in vivo image that you get on the OCT of the femtolaser helps you actually delineate whether there is a pre-existing posterior capsular defect or not, and then plan your surgery accordingly. So what is important is the imaging, and I'll just show you, this is an image of the patient. Even on the slit lamp, you can see that there is a huge posterior capsular defect. It's a polar cataract. Now let's see how we work on the femto. So you can see that when we are looking at the femto, there is a pre-existing defect. Can you see this? This is a pre-existing defect that is there. So what do we do? Because there is a defect, what we will do is that these buttons that you have, this is defining the lower edge of the nucleotomy. So what we do is that we increase them or take them upwards, so that we leave behind a phaco-safe zone. So we have done the capsulotomies. You have a fantastic capsulotomy. So if you want to place the lens on the bag, like in the sulcus, outside the bag, you can do that. You can see that this is the intra-op OCT. The intra-op OCT, as you showed, was having an epinuclear plate, but there is no dehiscence just now. So what you see here is that I have been able to take out the entire nucleus because the nucleotomy helped make it a very easy thing for us to aspirate. Now just see at the huge defect that is appearing. And now we put viscoelastic. You see this huge defect is there. You can see a blob of vitreous on the intra-op OCT, and you can go ahead and put the lens in the bag. So friends, what I wish to say is this is the photo essay on the same. You could see very much on the slit lamp, as you can see here, a pre-existing posterior capsular defect. You could see it when you were doing the femto. What you did was that you increased the default, you took the nucleotomy up so that you are leaving behind a thick epinuclear plate which will not be disturbed till the very end of the procedure. Even if you use the IOL Master 700, you could see this defect. So slit lamp examination, pre-op OCT also, and even IOL Master 700, etc., can let you know and caution you that there is a defect and you have to work accordingly. And this is the microscope integrated OCT. Again, you could see this is the huge fluffy matter which was going into the vitreous. And this is, once everything was cleared, you could see a blob of vitreous coming out. So friends, posterior polar cataract is something which is fantastically held, kind of done when you are doing a femto. This is a Malugan ring. If you have small pupils, you can easily work with a Malugan ring or a BX ring and do that. And this, thanks to Dr. Kumar, that's his video. You can see that this is a case where we are putting in a Malugan ring. And once you put in a Malugan ring, you can go ahead and do a femto laser procedure. As you can see, we have dilated the pupil now, and we can take in and do the femto laser procedure. And this will help us in this particular case to go ahead and do the entire procedure. So you can see we have a pre-chopped nucleus with the Malugan ring. People said, if you have a post-RK patient, you can't do a femto. All you have to do is that you have to try to make the energy higher So what we do is that we make a higher energy, and you can see that it's a fantastic capsular access that is there. Rest of the procedure is about the same. Only if you are thinking that there is a problem, you should always use trypan blue so that you don't miss out any skip areas which can come below the incision. So a femtolaser procedure below a already operated RK is very much there. Now this is the case which was having a trauma, and we were doing a femto procedure in this. You can see that this, can you see this subluxation? This has a post-traumatic subluxation. When you are using a needle to do a capsular access, it is very difficult. But the femto will give you, irrespective of whether there is vitreous there or not, whether there is a subluxation or not, you can center the capsulotomy onto the capsular bag, and you have very little problem in removing the pre-chopped nucleus which is there. So subluxated cataracts, again, a fantastic tool that is there. This patient had a trauma. Because this patient had a trauma, he had a fixed dilated pupil. So we are doing SFT in this particular case, and you can see once we go ahead, do the throws, and we do two SFTs, top and bottom, you see how well the surgery has completed. So any subluxated cataract, polar cataract, these are my preferences of choice. If you have a patient with an ICL and developed a cataract, again, certain things in the complex cases, you can see here that this is the area where this is the lens, the ICL, but this can kind of mimic the anterior capsule, and you could see that the pupil was read as the optic of the ICL. So again, you have to be very careful that you have to bring the pupil up. And now you can see, I always put trypan blue because if there is any skip area, we can see that. And now go ahead, you can actually explant the ICL which was there. Once you have explanted the ICL, then it becomes a routine phaco. So I prefer, again, a femtolaser procedure because you get a great capsular access in these particular cases if you are clear about where you want to go. Now this is a phacomorphic glaucoma. If you touch this phacomorphic glaucoma with a needle, you are 100% going to have, look at the intumescence of the whole thing, you are going to have an Argentinian flag sign. You can see that this is so near to the posterior part of the cornea. Just look at the huge explosion that came in, that is the fluid that came out. And you can see that because we are doing the capsular access on a closed chamber, please remember closed chamber phacoemulsification that you are doing, you get a good capsular access and you don't get a runoff of the capsular access. This is angle closure glaucoma. You can see this patient had angle closure glaucoma. Iridotomies were done, didn't help. Just see the thickness of the lens. You can see it's a huge thick lens that you have. The answer here is 5.8 millimeter. You do whatever you want to do, the pressures will not subside. Just go ahead, do a femtolaser, do a cataract surgery, see how the whole thing falls back and the pressures get controlled. You can see again the anterior picture, the huge difference that is there from the previous one. If you see this previous picture and you see the picture, and you see the picture now. This is the PI. So again, this is a treatment of choice because the chamber is shallow, everything is shallow. You can go ahead and do a femtolaser to relieve the problem. Rock hard cataracts. When you are doing a rock hard cataract, again, you can get a reduction in the phaco time that you have, because as long as you can see through the hard cataract, just see the bubbles that came out, and you can see this is a black cataract, this becomes a pre-chopped cataract, and even in such black cataracts, you are able to actually do a phaco procedure or a femto procedure with the pre-nuclear chopping that has happened. So friends, these are a couple of the cases which I would wish to bring out to you, that femto as a routine, fantastic, but the bar goes up the moment you are looking at difficult cases. And these difficult cases are, some of them I have shown you, where I would, even if I have to pay from my pocket, I will ask the patient to definitely go in for a femtolaser procedure, because as the technology has advanced, and this has really taken things of the complex cases to a different ease that we have. And friends, I would say it's the time to take the leap of faith and switch over to the power of femto. So to conclude, there are several devices and aids which have come along with the femto. You use these devices and you are able to get excellent results. The only negative side is the costings that you have for buying the machine and per procedure cost. But I think patients are willing to pay, and if you can give them the guarantee of safety, you would be happier doing the procedure with femtolaser assisted cataract surgery. Thank you very much for your kind attention. Thank you. Just any questions or any comments anybody has? Okay.
So I think, your point is well taken, and while there may be a lot of, critics of laser cataract surgery, but I firmly believe that in many of these situations which Dr. Mahipal showed, I personally also feel that it adds huge value to both the quality of the surgery and the safety and the outcomes, and it definitely makes the surgery much more predictable and risk-free for the patient as well. And so there are several situations where I would, electively choose, for example, intumescent cataracts, pseudo-exfoliation eyes, and eyes with hard brown cataracts, posterior polar cataracts, RK eyes as well, where I would sometimes, there have been situations where I actually offered an upgrade to the patient where patient could not pay for it, and we absorbed the cost and yet we went. So that kind of, conveys that it does add a strong value to the procedure as well.